All right, I would like to go ahead and call this meeting to order of the Committee to Study Long-Term Managed Care. My name is Jim Kofalt. I am chairing this committee. I am a state representative representing Hillsborough 32. And we have Jay Markell and Janet Lucas here with us as well. So first order of business is to review and approve minutes from the previous meeting. So thank you to Kristen Grant for distributing those. And I understand the other members of the committee have had an opportunity to review those. Are there any comments or corrections?
None from me. I've read them.
None.
Okay. I think the only comment I had was, and now I have to find it. Yes, so there was a reference to O3B in one of my comments. And so just so that people are aware of what I was referring to, I often will refer to the One Big Beautiful Bill as OB3. So I don't know if we want to call that out specifically, but just so that people are aware of that. So if we could sort of say OB3 and then in parens, One Big Beautiful Bill, so that people are clear about what that is referencing. So with that, I will ask if we are in agreement on that change and approving the minutes with that change. All in favor?
Aye.
Okay, minutes are approved. So the next order of business is we wanted to hear testimony from stakeholders. I had invited people to email Kristen Grant and myself last time. If you have not heard, if you've done that and you haven't heard back, then I apologize. Those who emailed me exclusively, if I fail to respond, then I will take responsibility for that, and I would ask you to reach out again and just let me know. Otherwise, I think most of these folks here in the room should be scheduled for either today or Monday. I do expect we will probably have a meeting either late next week or the following week. Given the calendar schedule, I'm guessing it will be the following week at this point. So on the agenda for today is Granite State Home Health Care and Hospice Association, followed by the New Hampshire Association of Counties. And then I have also invited DHHS to provide their input. I think they have some additional materials that they shared with us this morning that I would ask them to give us some additional information on towards the end of the meeting. So first order of business then, I'm going to invite Granite State Home Health and Hospice Association to come forward and take the microphone. Also, for everybody's reference, we have requested that these meetings be live streamed, so they should be available on YouTube as well, and the future meetings should be available via YouTube. So please go ahead and introduce yourself.
Thank you. Good afternoon. My name is Kellyanne Totten. I serve as the CEO with Granite State Home Health and Hospice Association. We are the advocacy affiliate for the Home Care, Hospice, and Palliative Care Alliance of New Hampshire.
I'm Amy Moore. I'm the board chair for the Home Care, Hospice, Palliative Care Alliance and from Ascendria Care Alliance.
Could you spell your last name,
Yep.
please, Kellyanne?
Totten.
Thank you.
Sure. So thanks for the opportunity to be here. We'd like to just provide some information about home care in New Hampshire in its current state, our thoughts with regards to managed care services and some considerations, and happy to answer any questions that you may have for us. One request that we would have is a call for inclusive planning if possible, during the study committee phase or next steps. When we think about home care agencies, often we use the term home care, but within that, there are 3 to 4 different types of home care providers. There are some that simply provide, not simply, but acute care services, post-acute care. There's private pay only. There's also Medicaid, Choices for Independence only organizations. We have some that do Medicaid, private duty nursing only. And then there are some agencies that offer multiple of those services I just spoke about in one agency. And my point in sharing that is sort of no 2 home care agencies are the same. So some may operate under multiple licensure types and have different regulatory guidelines to follow. Some may provide post-acute only, some may provide non-medical CFI only. And so any work that would require a combination of the dual eligible population, things like that, we would be talking about coordination across different provider types and agencies as well. Also, I would recommend, and this was spoken about in the first meeting, but the importance of what our rural northern home health agencies experience from a barriers to care reality, which is different than what we see in the southern part of the state. So if there's an opportunity to involve providers from different regions of the state, that would be important for planning as well. Also, just recognition of the diminishing impact of the 2023 rate increases for Medicaid CFI. While that was extremely helpful at that time, it is important to share that our agencies did initially experience a boost in recruitment and retention, but those benefits have begun to erode as continued pressures with inflation and increased costs continue to go up because we continue to compete with other industries. So you could go work for a fast food restaurant and make more than you would delivering personal care where you're required to have your own car and provide transportation to these critical in-home visits. So workforce is still an important reality that would need to be addressed in any planning going forward. And that really falls into the capacity to absorb any additional burdens, which sometimes just change management in and of itself can be a burden. So our Medicare certified home health providers, some of which additionally provide CFI services, it's important to note that currently we are facing a potential CMS proposed cut of 9% to our Medicare home health payment rate. So I just came back this week from Washington, where we are doing everything we can to hopefully freeze cuts for at least 2 years so that we can stabilize our workforce and revisit the calculations and math that CMS utilized to come up with those cuts. Happy to provide added information there, but I think what's important for this committee to understand is some of our Medicare certified agencies have stability or have had stability in the past from Medicare services. In the absence of that, the reality is they would have to look at cutting service area. They would have to look at cutting certain service types that are just no longer feasible. So it would be an important thing for you to be aware of, some of our larger post-acute service providers. Also, our smaller agencies lack the administrative and technology support to quickly respond to changes from a payer perspective, or if it's a change in practice. Again, just noting the importance of a methodical, well thought out timeline. We noted a few recommendations as well, which I think are in line with the comments we provided. So really asking for a phased, cautious approach, consideration of regional pilots before, if it were to move to full implementation. We would also ask that we explore managed care planning in alignment with targeted workforce investments including wage stabilization strategies to help support recruitment and retention. Also, considering building in mechanisms for ongoing feedback from frontline providers and agencies to ensure that future decisions can be informed by those delivering the care day to day. And we can pause there and answer any questions with regards to home care agencies and Amy as a CFI provider as well.
Could you elaborate on the possible services that might be cut?
Sure. So some agencies offer the post-acute skilled care. They may have some CFI, Medicaid waiver services. They also offer community benefit services that people may not be aware of. So that can be charitable care for people who are underinsured or uninsured, which we may also see an increase in the near future in our communities as well. And they offer different clinics out in the community, things like foot care services, education around advanced directives. There's a variety of what our agencies provide in the community. Also caregiver education, caregiver support, Alzheimer's and dementia programming. So there are different things that each agency may offer. From a community benefit perspective, things like that wouldn't necessarily be possible if they continue to experience cuts.
Thank you.
Sure.
So I have a couple of questions, and I'll let Mr. Lippman know. I'll be asking him these questions as well because I think he's going to be the authoritative source probably. But I'm just curious about two things. One is you talked about a phased or cautious approach, and one of the items you mentioned was potential of doing a regional pilot. And part of my concern there is, if we're different parts of our state have very, very different needs, as some of what you have spoken about has pointed out. I'm curious as to what you might suggest, what that would look like, so that we could get an accurate assessment of whether this works for New Hampshire, whether it works for northern New Hampshire, whether it works for more populous parts of southern New Hampshire. So that's one question. And then the other, and again, I'm not sure whether this is in your domain or not, but as part of the One Big Beautiful Bill, there was also this Rural Health Transformation Fund, which will probably amount to about $500 million for New Hampshire over 5 years. And I think part of that is, how can those parts of our state which risk being underserved invest so that they will be better positioned. So given your comments about change management and the need for a phased approach that offers some time to transition, I'm curious as to how you see that potentially playing in this. So phased approach with regional pilots and then rural health transformation.
Sure. So I think what my thought is with proposing a regional approach for pilots was to look geographically at having different partners as well as agency size. So I think it would be valuable to have an organization that provides the post-acute skilled care and CFI. It would be helpful to have a non-medical CFI only organization, and then also consider having at least a rural portion of the state and then a southern, more populous portion of the state in addition to that. So geographically diverse, but also provider type and the services within an organization would be helpful.
Okay. That
Does that
sort of fits with what I was expecting I might hear. So yep.
Okay. And we are familiar with the Transformation Fund and have reached out. So the hope is we have actually a meeting coming up next week to have some discussions with regards to potential opportunities for home care providers to be included in some of that planning. There could be opportunities for services such as telehealth, As I understand it, and certainly Mr. Lippman would be better poised to answer this than I am, from a funding workforce perspective, I think that there are some restrictions from the sense of it can't be used for rates, and it can't be used to necessarily be given to an agency to use for recruitment and retention efforts either. So from that workforce potential, I don't know that it can help in the workforce stabilization piece unless there's a funding stream to help with the wage challenges that we experience in the state for Medicaid.
Okay. So just as a comment, I understand also as part of the bill, some changes have been made to Pell Grant funding, which could potentially be directed towards some of that workforce enablement. So sort of a shift in focus toward workforce enablement and to a greater in shorter term programs that get people into the workforce more rapidly, and that may be something also that we could recommend coming out of this committee. So
Yeah, we have a pilot happening right now with it's the New England Home Care Nurse Residency Program happening here in New Hampshire. It was a Department of Labor grant from 2024, and so that could potentially be an effort, and that's really boosting and strengthening the clinical side of our certified home care providers as well. But so that could potentially, and it does strengthen all providers as well.
okay, could you tell me again what you were calling that? And
Sure, and I can send our information on this program afterwards. It's the New England Home Care Nurse Residency Program.
okay. And is that a program that's ongoing, or is it?
So it's a
wrapping up as the-
demonstration grant.
Okay.
So at this point in time, we've learned a lot through this first implementation phase. And one of the things we've learned is truly some of the barriers that exist from a capacity perspective at our organization. So some agencies are able to hire a new nurse graduate from a bachelor's degree straight into home health. Just for comparison's sake, I worked in home health for nearly 20 years. When I first started, you would never hire a home care nurse that didn't have a minimum of 5 years experience in a hospital setting. So the shift of culture to consider hiring a new grad does require additional training and enhanced support to help retain a new grad so that they are also successful in the field of nursing in the home care setting. It's required new partnerships with nursing schools throughout the state, as well as our agency partners. And so we have a cohort right now of 5 new nurses that are associated with agencies in our state. We have 1 participating from Connecticut. Part of our sustainability was to explore the opportunity to have this generate some income, so it's not grant dependent. But that's also a challenge just based on the current state.
Okay. Other questions?
Not at this time.
Okay.
Sorry.
Go ahead.
I just wanted to, I think, we're all very, open to all this and want to have discussions about it. The main reason we're here is just to make sure that there is a clear and accurate picture of where our system is at right now, so that there aren't unintended consequences and that the time is taken. Because we're already in a space of it's not just the workforce. We know we have a aging population. We know we have federal stuff coming down. And this has been years and years of our industry struggling, that death by 1,000 cuts. And I've seen in my 17 years, so many just CFI providers alone stop doing that work. And I just want us to be cognizant of that as we move forward.
Okay. Yeah, I guess I do have sort of another question that's maybe a little bit general, which is sort of, you talked about the transition and some of the challenges associated with the transition. You used the phrase change management. You talked about billing systems, sort of transitioning to sort of new particularly new models around billing and payment. What so are there measures that could be taken to alleviate some of those concerns, and what might that look like?
I think really in pointing that out, it was to stress the value in if this were to become a reality, meaning managed, Medicaid, that we take our time and that it's not, something that we are looking to move to implementation in the immediate future, just giving some time for us to absorb what we foresee could be some challenging healthcare situations in the next year with changes to Medicaid potential. We don't know yet what's going to happen with CMS and our proposed rule. So it was more a matter of we need time to digest what's happening right now and be a part of planning so that we're really hearing from our providers what the reality from an operations perspective would look like.
Okay. Any other questions?
No. Well, wait a minute, just one question, or perhaps I'm a little out of it here. In terms of hospice, or your New England program where you're getting the nurses now straight out, are they going to hospice care? Are those the
Not
ones?
at this time.
Okay.
No, they follow different, they have different regulations and program requirements and assessments. And so right now we're focusing on the home care side. That would be a natural next step if or when we can stabilize or really launch fully the home care program.
Okay.
Yep.
Thank you.
So are the people who are participating in that, are they're LPNs when they
No,
go out into the
they
field,
are
or they're working toward
they
an
are
LPN?
registered nurses,
Okay.
but they have not yet worked in a clinical setting.
Okay.
Yep.
Excluding their training,
Correct.
their clinical training.
Correct. They haven't started a career yet.
Right.
Yep.
All right. Looks like that's it. Thank you.
Thank you.
Thank you.
All right, next I'd like to call forward the New Hampshire Association of Counties. Welcome, and if you could just begin by introducing yourselves and spelling last names if necessary.
Good afternoon. My name is Craig Labore, Labore. I'm the nursing home administrator at Grafton County Nursing Home.
And my name is David Ross, ROSS. I'm the administrator of Hillsborough County Nursing Home.
So we both want to thank you for the opportunity to come and speak before the committee this afternoon. I wanted to take a few minutes as part of our presentation to just recount a bit of my experience with this subject. In the initial series of discussions that dated back between 2016 and 2018 on this subject, when Medicaid managed care was first being discussed and the potential implementation of what was at that point called Step 2, including the long-term services and supports program. I happen to serve as the president of the county nursing home affiliate, and so I was involved and part of a group of that was with the Association of Counties, along with DHHS leadership, and we studied alternatives to what was originally being proposed as a full managed care model for the long-term services and supports program. We also, through this work group, had two national healthcare consulting firms joining us in that work. And so we had a great opportunity to have very thorough discussions about this subject and its use across the nation, and how each state was, kind of looking to manage the long-term services and supports population. This group, we evaluated all the different models that were out there across the country, and we evaluated whether the potential for replication in New Hampshire could take place at that point. Both consultant firms agreed and identified on several challenges facing New Hampshire's long-term services and supports program at that time. One of the biggest challenges was that the system as a whole was not funded well. Investments in the system were needed to stabilize operations for providers and improve workforce and services to enable greater utilization of community-based care, which was and remains to this day the most cost-effective use of long-term services and supports dollars. Given the Association of Counties' role as the primary payer for non-federal share of Medicaid funding for the long-term services and supports program, counties also had specific concerns related to the likelihood of what actual cost savings generated by the managed care plans managing the long-term care, long-term services and supports population, and the fact that a move to a managed model would jeopardize two important funding streams for providers: the Medicaid Quality Incentive Payment Program, and from the county's perspective, the Proportionate Share Payment Program, again, which is something that only county nursing homes have access to for funding. I think as we sit here today, the association believes that the concerns identified in 2017, which resulted in the elimination of Step 2, are still present today. The system remains underfunded. A large number of providers are struggling to operate in this environment, given continued rising operating costs and not seeing a corresponding increase in reimbursement. And also, a move to a managed model for long-term services and supports delivery would mean the end to the Medicaid Quality Incentive Payment Program and the Proportionate Share Program. The Medicaid Final Rule of 2016, which to our knowledge is still in effect, expressly prohibits supplemental payment programs to providers enrolled in a managed services and supports model. The loss of this funding alone would result in roughly $60 million revenue hit to New Hampshire counties.
Can I ask a question?
Yes.
Sorry to interrupt you. That 60 million would come out of the MQIP and the ProShare,
Correct, both programs. Yeah.
and that would be for the entire state, 60 million.
For New Hampshire counties.
Thank you.
To be clear, that does not include the impact that it would be to private facilities. That's just for the county.
Just for the
facilities.
county.
Just for the county.
Just be the county facilities.
As the Association of Counties evaluates where we are with the current long-term services and supports programming, we question why we are here today discussing a potential move forward, implementing a managed long-term services and supports model. One of our biggest questions that remains today is where this value that managed care companies will bring to this program. Long-term services and supports providers are already managing this population's needs as required by federal regulation and state contracts. In 2017, it was projected that managed care companies would take upwards of a 10% cut from contract funding to cover their administrative operating costs for managing the program. The system could not afford to lose those dollars then, and it cannot afford to lose these dollars today, given our continued inadequate reimbursement. As I mentioned in my earlier remarks, utilization of community-based care is the most cost-effective use of long-term services and supports funding. In 2017, New Hampshire ranked 48th in the nation, ahead of only Alabama and Kentucky, for reliance on nursing home utilization. At that time, roughly 70% of New Hampshire citizens over the age of 65 were in a nursing home.
Would you repeat that, please?
At that time in 2017, roughly 70% of New Hampshire citizens over the age of 65 were in a nursing home.
Do you have an updated figure?
Yes,
You're getting there?
I'm getting there.
Thank you.
Recent data issued by DHHS and used in Governor Ayott's budget showed that in December 2024, this number had dropped to 51.7%, which is almost a 19% decrease. We believe that this statistic demonstrates the great work already being done by DHHS staff in bending the curve on nursing home utilization, and once again leads the Association of Counties to question where the value add is with having managed care companies involved in the management of this program. And if I may, just for a moment, try to create an analogy. The long-term services and supports program could be viewed as a big cruise ship, right? And so if you're bending a curve and trying to turn the cruise ship around, it takes time. You don't make a U-turn like you're driving a Porsche and just like that. It takes time. So the amount of time that has passed from 2017 to today's date, where that data came from, of a 19% decrease, demonstrate that the state is moving in the right direction in shifting reliance on nursing home, utilization of nursing home beds, and shifting that towards the community-based care model, which is something that the association is very supportive of, and again acknowledges the great work that the department is already currently doing. And we want to continue to work with the department in that goal to help us continue to bend that curve.
So I'm going to ask a question. Forgive me if this is a dumb question, but what role do the nursing homes play in? I think you said you're playing a role in that community-based care. So if somebody's getting care in their home, how do county nursing homes play into that?
The county nursing homes don't necessarily play a role in that aspect of it, but we do partner with the state in discussions at the county state finance committee level. And so from our role as primary payers of the non-federal share of the Medicaid program, we have a seat at that table and are able to communicate and work directly with DHHS leadership on their program initiatives and provide feedback into that process.
Okay. And I understand DHHS has been also undergoing some continuous improvement programs to sort of accelerate the approval of eligibility. So yeah, so it sounds like that is probably contributing to those numbers looking better over time as well.
Correct.
Okay, good.
I think what also contributes to that is the moratorium on nursing home beds, which we all support. That as our population ages, the need for long-term services and supports is going to dramatically increase. There is a moratorium on nursing home beds, so there will be no increase. That population is fixed. So in order to provide services for folks that are needing it, we are going to need to continue to build capacity into our home and community-based care system. That is the state already has a pathway forward to implement the objectives of a managed care system, because we know that we can have no more capacity added into the nursing home sector. So we have to build it into the community-based care. And that's going to dictate that we provide care in the nursing home for those that are the sickest of the sick and the most frail, that can't receive cost-effective services in the home. We recognize that and we support that. I think that adding another layer with a managed care organization who is taking funds out of a system that is already struggling with funding isn't the pathway forward. And I think that we collectively need to be working together to try to figure out how we manage that.
Okay, so and just going back to a statement you made about MQIP and ProShare. So forgive me because I'm still trying to get my head around the OB3 bill. But you're saying essentially that those supplemental payment programs are not allowed under the OB3.
They are disallowed, and those programs are not funded at all through general funds within the state. Those programs are funded through providers directly,
Yep.
And with federal matching dollars. So taking that $60 million for the counties out will automatically put that burden to cover those costs on county taxpayers, and will put pressure on the general fund to be able to support that difference.
Okay, and my understanding was that sort of those provider taxes are frozen where they are and will be phased out. And can you remind me do you know what the phase out period is for that?
I do not know. I know that it is frozen in the current.
Okay,
Yeah.
Right.
Mr. Lippman probably knows that.
Mr. Lippman probably
Yes.
does, yeah. Yeah.
Just so for the recording,
Yep.
Henry Lippman, State Medicaid Director, the nursing home tax is not reduced. It is frozen, as you said, at the 5.5% currently. So
Okay.
hospitals is the one that's going to be being reduced eventually to 3.5%.
Okay, thank you. Other questions?
Yes, in terms of, thank you for your presentation. It's quite comprehensive. So if we're talking about long-term care and we're making it community-based care rather than the nursing home, am I correct in perceiving that as the focus?
I think it's, long-term care has to include both nursing
Nursing
home
home
care.
and
Has to
community.
include both nursing home and community-based care.
Right, but to the extent that we're trying to shift the focus to community-based care. Okay, so then I was reading some of the handouts earlier. So what kind of diagnoses do you get that are most, I guess, most amenable to community case-based care as opposed to the nursing homes, where you're going to need round-the-clock, 24-hour, 7-day-a-week care?
It's not diagnosis-based, it's really need-based.
Need-based.
Yeah, and the amount of supports and services that someone is going to need. It will also depend on what type of existing supports that they have in place currently, what their housing status is, how close they have proximity to additional services and supports. If they have transportation services available, it really will be individually selected.
Okay, thank you.
What's the current wait, if you know, to get into a county nursing home on average in New Hampshire?
We don't have those statistics on average. I know that it can be 3 to 6 months or longer. Yeah.
Okay.
I know at Hillsborough County, we have a wait list right now of over 100 people.
Can you tell me,
At
oh, I'm sorry.
Grafton- I was just going to say, at Grafton County, we have a wait list. We're a smaller facility and less populated area, but we've got about a 40-person wait list at our
Okay.
building.
Can you tell me about what the average length of stay is in a nursing home?
Less than 2 years.
Okay.
Yeah, ours is 18 months. at
Okay.
our-
Other questions?
Not for me, thanks.
All right. Thank you very much.
Thank you.
So I'd like to invite DHHS to come forward and talk a little bit about, you can comment on some of what has been said so far. Also, we received some materials. I received them sort of late morning, so I didn't get a big chance to look at them, but the dual eligible special needs plans. So I'm wondering if you could just give us an overview of that. I think the materials that you sent the committee were very helpful, but I wonder if you could give us an overview of that in addition to what you've sent, because I don't believe my colleagues here have had a chance to see it yet.
Sure. On speaker. There we go. Dual special needs plans is a flavor of managed care that can be done in there. Within dual special needs plan means people who have both Medicaid and eligible for Medicare, so that you can integrate those two together to provide better care coordination and to leverage some of the benefits that are in Medicare that aren't in Medicaid and vice versa, and to have strengthened care management. There's in dual special needs plans typically in our current MCO contract, the state has, with the 3 MCOs that we have a contractual right to move in that direction, but just taking one further step back, where this all came from, why we did this study is in 2023, the legislature did the system of care for aging and disabled, and I think out of that there was some funding to do an analysis of the dual special needs plans, as well as an acronym known as PACE, Program for All-Inclusive Care for the Elderly. And basically, dual special needs plans is, I won't get into all the different acronyms here, but we'll call level 1, level 2, level 3. There's one where you can marry the Medicaid and Medicare, but not include long-term services and supports in it. But there's still, and I think Indiana would be an example of that, where by putting the two together, they were able to still see some increased use of home and community-based services like CFI. And as you may remember, or if you don't, just reinforce that CFI, the Choices for Independence program, typically has a cost that's 1/3 of what it costs to keep someone in an institution. One of the things that colleagues before need to also add is that for residents of their county, they are paying for the services not only of the people in their nursing home, but in any nursing home, as well as in the Choices for Independence program. So the entirety of LTSS, long-term services and supports, is part of what the county cap helps fund. And so I think that in terms of what was some of the comments before us, like the home care folks that spoke, the concern about the fragility of their situation in terms of how quickly a program is stood up, I think that's where you would have a concern there. There are, if the legislature moves in the direction of managed care, there certainly the rural healthcare transformation program could be of some support. I think, as was mentioned, it can't be used to reimburse services. It's the purpose of the program is to sort of enable enduring productivity changes. Like, for example, it might be a technology investment to be able to do a service that by telehealth or remote monitoring. There is funding for potential for workforce. The issue that we have, the way that OB3 structured the accessing those funds, is that we have to put together a plan and an application between probably next week and submit it by the 1st of November. We have one chance to submit it for a 5-year period. So in terms of the chance to really, we are doing stakeholder engagement, but the ability to sort of develop the best plan possible in a 6-week time frame is a little bit challenging. But I think in terms of things that would be able to support, no matter which direction the state goes into, in strengthening home and community-based care and long-term care, that's part of what we can build into that grant. So I don't want to say that there's nothing we can do there, because I think there is. But getting back to the other issue that came up was, can you implement on a regional basis? There is, I believe, the possibility through waiver to be able to do regional implementation. I think the issue is that our state Medicaid program, compared to the rest of the country, is pretty small. Where we have today about 1 in 8 citizens in the Medicaid program, and we're the 4th smallest program in the country, because many states are like 1 in 5, 1 in 4, and some are even 1 in 2 or 1 in 3. New Hampshire has a smaller base to work off population-wise within the Medicaid managed care space, which if you reduce the number of people, can make it harder for the managed care organizations to operate efficiently. That's not to say it can't be done, and I think you should hear from them, but that is, I think, one challenge of doing it in regions. I think from my perspective, it'd be better to take a little more time to plan the implementation than to maybe break it up. But it is a policy option. So in terms of, getting back to dual special needs plans, that, I think the effort there is, do you get someone involved in a Medicaid plan? And if the insurer is also a Medicaid managed care organization, the resources that are coming in from Medicare and Medicaid can be combined to provide potentially better services. The issue how that gets translated down from the insurance companies to the providers is the concern that I think you picked up from the first speakers. There are ways that in a program the state can do what we call a form of a fee schedule. We can have a fee schedule that they have to follow in certain instances. I think the other thing to talk about here in terms of from the county perspective, their challenge with a program that includes long-term care, I think they would see the value of a dual special needs plan where it increased the use of home and community-based services because that's less expensive for that to be financed. In terms of long-term care, I think the concern is that the money that they put in, typically in managed care, sometimes you're getting paid less than what you would in a fee-for-service environment. So that's one concern. The second concern you heard was what happens to their pro share and their MQIP payments. There may be some ways to work around that issue, but understanding the level of risk there in terms of the amount of payments, I don't have a solution today to say this is how we could do it, but I would imagine there may be a way to address that, but it may come with some additional risk. For example, it may be tied to achieving certain metrics, whereas like the pro share is to basically guaranteed payment based on your cost structure. So there's I think a concern there.
So you're saying that the concerns about ProShare and MQIP, or just ProShare, would still be valid concerns for the counties?
Yes, and I think that there may be a way around it, but it may come with some additional risk to them in terms of the ProShare, sort of a sure thing, and the MQIP is somewhat the same in terms of the how they can budget and count on that money. Is even with ProShare, there's the cost can fluctuate from what you expected, but there really isn't so much a risk there other than the amount of services and the cost you incur. And MQIP is based on an allocation of the patient days that you have against all the other nursing facilities. And so that's I think, back in 2017 when the study was done, that was lifted up as a concern. And something I think legitimately needs to be tackled out of concern of county taxpayers in terms of what the impact would be. I think that would take, the MCOs and other states may have some solutions there that they could offer. And I'm sure with the right group of people, you might be able to figure something out and just say it's not insurmountable potentially is what I'm just trying to point out.
If you don't mind, just going back over the point about New Hampshire's smaller Medicaid population and how that would affect the efficiency potentially of managed care. If you could just spell that out in a little bit more detail for me.
Sure. Today we're running just under 180,000 individuals, and it takes about 50,000 is sort of the minimum that a managed care organization wants to maybe enter a market. They probably would like more than that. I think in one sense, adding long-term care into the program is they would see as a positive thing because the revenue per member, because you're covering more services, would be larger. So that is, if you will, favorable to them. But when you start to carve off counties, as an example, that the benefit of bringing in the talent to work with them to administer a long-term care program may be more challenging if you break it off. I think they probably would prefer, they should speak for themselves, something would go statewide, with time to, plan for it.
Thank you.
So the materials you sent reference a feasibility study by ATI Advisory,
Yes.
and I'm wondering, does their report, well, is their report complete and available, and does it include a financial analysis of that impact where you may be getting more? I'm interested in knowing if there's a sort of an overall financial impact, and then if there's a financial impact assessment for various parties like counties, for example, or private nursing homes.
I think the study looked at whether it was feasible population-wise and sort of cost-wise, both for dual special needs plans, and it also looked at the program for all-inclusive services for the elderly, the PACE program. Both are possible. The PACE program was seen more in the more urban areas of the state than in the rural areas. I would say, though, that when I was talking about dual special needs plan, if you picked up, I think, was it today's paper or yesterday's paper, it was a front page story in the Union Leader, talking about, insurance department was talking about what may be happening in the Medicare Advantage program. When you're talking dual special needs plan, it's really, you're combining a Medicare Advantage program with a Medicaid program. When this report was completed, the if you will, the shakiness of the program in New Hampshire is much more potentially prevalent based on what we see in the news this week. But I think the concept could be, it doesn't have to go all the way to get some benefit to potentially patients and to the state's finances, but it does cause me to have some pause in terms of, we would have to have each of our MCOs have a plan. Today, only WellSense is the only one in the market that has a Medicare Advantage plan. Centene had one, but has pulled back on that. I think all the MCOs have sort of indicated to us in conversations that they're willing to relook at that if we went in that direction. But whether they would need full LTSS to make it worth their while financially is, I think, a question for them versus a more limited plan that just coordinated care and sort of on the acute phase, if you will. But Wendy is here, who oversees the CFI program and worked with the consultants along with my deputy director, who unfortunately can't be here today. But if you'd like to hear a little bit more about the study itself.
Please.
Well, hi, for the record, Wendy Altman. I am the Bureau Chief at the Bureau of Adult and Aging Services. And I, as well as representation from the Division of Medicaid Services, worked with ATI Advisory and are continuing to work with them. We first conducted the feasibility study, and I know that you have a question about whether or not that information can be made available to you. So, I'll take that back with Henry so that we can look at, how we would make that available to you as a follow-up. But we wanted to provide, as part of the document that we sent you in preparation for today's meeting, just give you a high-level overview. Henry did speak to some of that. Currently, with ATI, we have developed a high-level project plan for what it might look like to implement a dual eligible special needs plan with the 3 MCOs, and we collected feedback from the MCO community and internal staff at the department who would need to have a role in operationalizing the program. Currently in New Hampshire, we have 31,000 dual eligible individuals, and those are individuals both eligible for Medicare and Medicaid. And so as a population, dual eligible individuals have higher prevalence of behavioral health and long-term supports and services needs, and chronic conditions which require benefit coordination and care coordination. So dual eligibles receive that health care from both programs. And so we look at a DSNP or a dual eligible special needs plan as something that can complement that for those individuals who would choose to be in a plan. And nationwide, just another, snippet of information, 43% of all dual individuals, so as of 2025, they operate in 46 states, and New Hampshire is one state that does not operate. One of the small amount of states that does not operate that. So that was another motivation to really look at how that can benefit individuals. And our primary lens to this was looking at how we can improve the care for dual eligibles here in New Hampshire. So through the what we would call a state Medicaid agency contract, or a SMAC acronym, would be a specific contract that would happen between the department and the MCOs, which would provide some additional measures and requirements to sort of shape and customize what that service would look like through the dual special needs project. So it would not be just, what's federally required, but we can also add and customize at a state level what that looks like with the managed care organizations. And that would be a separate contract from what we currently have at the department for a contract. And so through that, we would have significant authority to influence how those DSNP programs would operate and how they would coordinate with Medicaid in New Hampshire. So ultimately, we see it as presenting an opportunity to provide value and offer benefits for that vulnerable population without or limiting any increase in county or state costs. So, we're hoping that we could look into this further. And as I said, we've identified with ATI Advisory a preliminary, operational plan for what that would look like and what would need to happen with a high-level timeline for when that could be operationalized. I think that we remain committed to continuing that collaboration and looking at design decisions that we would need to have discussions on and make decisions on so that we could launch potentially a program in 2028. And currently the work that we are doing with ATI has gone into another phase where we're looking at the program for all-inclusive care for the elderly, which is the federal name for that program, and doing a lot of learning and education to this internal department staff so that they're grounded in what PACE is and what that might take at the department to operationalize that. And the end product of all of that work will be to look at drafting a request for information or an RFI as a end product with the consultant.
I could add, I think, 2 points to the conversation so far. One is to going back to, I think, the first day that we testified, we do have the law in the books that has a prohibition against managed care and for long-term services and support. To move forward with anything, that law would have to be, changed. And then the second thing is that we've talked about the dual special needs plan as being an option. It doesn't have to include long-term care. Just want to make that point. That I think would still comply with current law. And again, the advantage there would be potentially the combining the two benefits, that there'd be more use of home and community-based care, Indiana being the example, The other thing too is that you could also move forward with a long-term managed care without coordinating with Medicare. And I think that's done in some places, but I think you're missing something if not combining the resources. And patients, I think, in terms of some of the the extras that come with a Medicare Advantage plan, they would miss those. And I think for people who are especially low income, that those extras are helpful for their life. They can be, some of the side benefits. There are, I think, challenges though still in with Medicare Advantage plans that some people have with them, and then also, leaving a Medicare Advantage plan and going to regular Medicare has some tricks to it as well that people have to take into account.
Are you aware of any studies that have been done looking at quality of care differences between the programs that we've been talking about today?
Off the top of my head, I can't cite them, but I'm sure that we can pull some. I mean, there are 46 states that are doing this. New Hampshire is sort of an outlier in that regard. That being said, I think it being an outlier is part related to our population size. I think that it's hard for insurance companies to work in this state with a small population, and it's hard based on how we finance long-term services and support in the state in terms of in many states, it may not be, the counties may not have the same financial responsibility as they do here in New Hampshire.
So in the materials you sent, there's also a note regarding presumptive eligibility for
Yes.
home and community-based services. So this would, and I'm just trying to understand how that fits into the other subject matter here. I think there's, DHHS has been working, if I understand, to accelerate the eligibility verification process. So is this addressing, probably would help to alleviate that, any backlog that still exists, but how does that fit into the larger discussion around DSNP and PACE?
Sure. In terms of today, to be eligible for Choices for Independence, you have to meet an institutional level of care in order to qualify. In other words, that you could, absent having the Choices for Independence extra supports, you could otherwise qualify to be in a nursing facility, but you choose, that's the choices part, to have services in the home to support you. The idea of the waiver, which was required for us to apply for in the 2023 legislation, it was to be able to provide some services before the eligibility determination is completed. Because oftentimes, people putting together that financial picture, that causes a delay in making eligibility. So if we see someone that we can say, hey, we can see this person really needs these services, but we can't make them eligible because they haven't, passed the financial eligibility as an example, we could provide some services in anticipation of that they would qualify for a limited period of time, which the advantage of that is you avoid institutionalization unnecessarily. In OB3, there's also a new option that has not really been laid out completely to the healthcare community. It allows someone to get services presumptively without having to meet the institutional level of care. And so, again, sometimes you see people that you would love to provide services a little bit earlier before they get to the point where they've deteriorated to that point where they need institutional care or, can stay home with extra support. So I think there's a recognition that we could do more to help people from becoming institutionalized by providing services earlier. And that I think fits into the program of whether you have managed care or not, which is, it's less costly whether you're an insured product or the state's financing it completely in fee for service to provide that care in the home in most cases.
Okay. So so we have a dual eligible population in New Hampshire of, you said 31,000?
Yes.
Okay. And so of those, sort of, do we know how many are receiving long-term services and support?
Roughly off the top of my head, if you were looking at both nursing facility and CFI, it's probably close to 8,000.
Okay, so.
So there's a lot of
little over-
duals who are
little over a
not
quarter.
receiving, or who aren't in a facility or on a waiver. We also have two other waivers that serve adults here in New Hampshire, which would be the acquired brain injury waiver and the developmental disability waiver.
Okay.
And those are, I think, another sort of policy choices, which populations do you add into managed care? Often I think CFI would typically be the first population, and then, I guess viewing more vulnerable developmental disability being the most vulnerable, and probably acquired brain disorder. I think when states implement a program like this, some do it all at once, some do it, population by population. So again, going to the conversation earlier today, is it better to do it by population or by geography in terms of how you roll it out? My sense, it would probably make more sense for New Hampshire if they were to go in that direction, do it by population.
Okay. Other questions, comments? No? Okay. Thank you very much.
Thank you.
Appreciate it. So I know this discussion about DSNP and PACE is something that may not have been sort of known on the agenda previously. So I guess I'm curious as to whether the folks from Home Care and Health and Hospice or from the Association of Counties would care to add anything to that part of the conversation.
Thank you. Again, it's David Ross from the New Hampshire Association of Counties. We have been working closely with the department on the exploration of PACE versus the DSNP programs. I think that the issue of PACE, I think we see that as a more advantageous program for us. However, it's not possible really within our structure as a state geographically. PACE programs require building a physical structure and really housing all services and providing all care out of that center structure. So we lack the infrastructure as a state to be able to help support that, both with transportation and access and just our general geography. And we see the DSNP option as something that may be more viable of those two. That being said, as our colleagues from the department just shared, there are a lot of unanswered questions that would need to be addressed before implementation of a DSNP program. Most notably would be the impact to rate structure to providers. One of the greatest barriers to expanding the provider network is the reimbursement system. So losing any funding into direct provider reimbursement is not going to incentivize growth in that sector that we do need. We do see an advantage, though, of pulling in Medicare dollars into that program, because that would incentivize potentially a greater network of services to be provided to folks at all levels. We heard from the Home Care Association earlier that the threat of loss of those Medicare dollars through proposed rate cuts would impact the availability of services that are not included in the Medicare program. We see that in the nursing home side as well, is that facilities participate in the Medicare program because reimbursement for that program helps to supplement the services that we provide to our non-Medicare patients, folks that are receiving Medicaid services. Because the reimbursements are so different. So the thought is that with DSNP, adding those federal funds into that program really might be able to enhance the availability of services throughout the state. That would really require a lot of review and due diligence to really see what does that look like and how many players would we be looking at from a networking perspective. You know, as Mr. Lippman shared, that right now there's only one provider in our panel that does have both a Medicare Advantage and a Medicaid program. So there's a lot of unanswered questions that need to be addressed. Worth exploring, though, for sure.
Okay.
Okay.
Questions? Questions? Thank you. And do you care to comment on it any further? Sure.
Kellyanne Totten, Granite State Home Health and Hospice Association. To my knowledge, I've been in this agency for the last year, but I don't have any direct experience with the two programs discussed here within the state of New Hampshire. I would just state some reservations, and again, wanting to due diligence with regards to involvement from Medicare Advantage plans and what that would look like from a partnering with home health agencies in the state. There can be some challenges with regards to rates and contracting with Medicare Advantage plans, meaning many pay lower than the Medicare rate, as well as requiring additional administrative steps on pre-authorizations for care and billing. So just some added reservations with regards to involvement there that would be important for us to be aware of. And we have some home health agencies that have had to opt to not contract with certain Medicare Advantage plans because they can't afford the rate and the additional administrative burden. So I just want to make that general concern.
Okay. Questions?
No,
Okay, thank you. All right, so that comes to the end of the scheduled presentations of people we wanted to hear from. I know many of you are had preferred to speak to the committee on Monday, so we will hear from others on Monday. In the meantime, is there anybody else who would like to offer input at this point in time? So we can have some discussion at this point on what we've heard so far, or we can defer until after we've heard from other stakeholders. My sense is that we're probably going to have a more fruitful discussion if we wait until we've heard from other stakeholders.
agreed.
Okay, so with that, I think we are complete with the business that we had scheduled for today. So barring any additional business from my fellow committee members, we will adjourn the meeting. Thank you for everybody for attending. And again, if you would like to address the committee Monday or at a future meeting, please reach out to us, either to myself or to Kristen Grant or both. Thank you.